Good evening. My name is Kayla Magwa. This is Vital Signs on the Frontlines. Tonight on Vital Signs on the Frontlines, we continue our on-the-ground assessment of Nigeria's emergency medical service system. Emergency medical services are about more than response. They're about systems, coordination, preparedness, and saving lives. Whether it is a routine emergency on a busy urban road or a complex, high-risk situation in areas affected by insecurity, the ability of the system to respond quickly, safely, and in a coordinated manner can make all the difference. Building that kind of system means being ready for everyday emergencies, as well as more demanding scenarios where multiple lives depend on rapid and organized action. On this edition of the program, we explore how these same principles are being extended beyond urban centers, reaching rural communities through the Rural Emergency Maternal Transport System, also known as RESMAT. For my guest, who is Professor Jibrin Ismail, Chairman of the National Emergency Medical Treatment Committee, emergency systems must be designed to function effectively, not only in routine situations, but also in complex and high-risk scenarios where both medical emergency and security considerations must be managed at the same time. Let's start with how the coordination works. It's not just government hospitals, also private hospitals.
Correct.
How does it work with private, how does the chain of command work in private hospitals? Let's say someone comes to a private hospital and is denied emergency care. How does that work with your office?
So private hospitals in each state are under the direct supervision of the State Ministry of Health.
Okay.
As well as licensing. And they are answerable directly in terms of their operations and their activities to the State Ministry. If there is any complaint by any patient, the local NEMSAS, that's if it's an emergency complaint, the local NEMSAS will take it up and it is part of the State Ministry of Health. And they will also inform us so that we can do a joint investigation to find if the complaint is valid. Certainly it is against the law in this country for any hospital, be it private or public, to deny care for emergency victims. So if law is broken, then certainly the case would have to be escalated.
So the emergency units in federal and state hospitals and private hospitals, are they audited?
Absolutely.
By your office?
We receive reports from the NEMSAS and we audit on need basis, but we don't routinely audit the private hospitals. Can
you give us some kind of percentage that is meeting the minimum standards for emergency care?
I would say it varies, depends on states, and then depends even on the state, on geography. For example, urban cities. In urban cities, you can find about 50 or 60% of them are really meeting the standard in terms of emergency care, but that would be different if you go to rural areas. States like Lagos are better than some of the states, so that is a very varying degree that we can say.
So let's talk about some of the trending issues, but not that we're going to take a look at them each, but basically it all comes down to the fact that this person shows up, an unconscious patient, shows up without an ID, no relatives, and many times we hear those people say, we were turned back. How is that supposed to work when someone doesn't have any ID on them, has a gunshot wound, some emergency? Who pays? Who decides?
Right. So that patient will be admitted as John Doe, and he will be treated as a patient under NEMSAS audit or NEMSAS account because at that point in time, he's considered vulnerable. Whether he is rich or not, nobody knows. Who he is, nobody knows. He has insurance or not, nobody knows. So the unknowns are to be treated under NEMSAS. And NEMSAS will take charge of the payment. If he was transported by ambulance, NEMSAS will pay for the ambulance.
This also applies to private hospitals?
Including private hospitals.
So for every Nigerian who's watching us right now, if you have a loved one or you know somebody who's unconscious or had to be taken into the hospital for an emergency, the person not having an ID or some getting police report and all of those things doesn't stop the person from getting medical care.
Absolutely not. And so what we advise at that time, call an emergency ambulance. Call the emergency number. Don't take the patient yourself.
Is that where the issue is? When you take the patient yourself?
Yeah, so the issue is for everything there should be check and balances, there should be control.
Okay.
NEMSAS has inspected hospitals and established their readiness to handle emergency and has accredited them. If anybody takes any patient to any hospital, nobody knows the standard of that hospital. Nobody knows if they are able to take care of that kind of emergency. But if an ambulance comes, there is a panel of hospitals depending on the cases. For example, a stroke patient will have to go to a hospital that have capacity for neurocare. But in a road traffic accident, will go to a trauma center. If that is not done, then you are not giving the patient the best. And that's why we insist in private hospitals, they should be brought by ambulance because that triage must have been done. And we know that that hospital is not only capable, but has already been accredited by NEMSAS as they have the basic capacity to do it. There are hospitals that do not wish to be on NEMSAS platform and they have not applied. So if an emergency goes to them, we don't know how they can handle it. We've just talked with you about standardization. They will not be part of that standardization care because they've not keyed in. Participating in NEMSAS program is a voluntary effort by an institution like hospitals.
The information out there for Nigerians, yes, Vital Science is doing what it can, but are there ways that NEMSAS can, community information, some kind of awareness campaign so people can understand that this is available to them?
Yeah, so at NEMTC level, we actually have a pillar that is on community awareness and advocacy and campaign, headed by our very own Mojima Konjola. And she's already created a media cell, and the media cell has had its first training on what NEMSAS is all about. And there have been programs on national media on NEMSAS, but also because NEMSAS relies on the states to implement. The different SEMSAs are given operational fund from the federal every quarter so that they can implement these activities, especially the campaigns. Some of them may have to be contextualized in language that people understand. And also, like we talked about, the emergency number, they may have their own emergency number as a secondary
number, yeah.
So we encourage them also to go into that, and we oversee to make sure that they provide that kind of campaign and information. There is a fund for local governments to implement some of these advocacy and awareness campaigns.
Well, there's one story from Maiduguri that is really outstanding and surprising to many people who didn't know that emergency services could work that quickly. And I'm talking about the 2 bomb blasts at the post office, and I think there was one at
the market.
At the market, where emergency services were able to pick up 61 people who were injured and take them directly to the hospital. And this angered the terrorists in a way, and they decided to go bomb the hospital, but they were intercepted at the gate of the hospital.
Right.
So let's talk about the challenges, because that shows emergency services in real time working, but also presents a challenge in places where you're dealing with insecurity. What kind of modus operandi does NEMSAS have to handle those sorts of situations?
Within the NEMTC, the membership included the police, representation of the police force. And we began to have discussions in select areas where there are, insecurity or threats of attacks and the rest. It would be a good idea that NEMSAS works in collaboration with the local security posts and respond to emergencies, especially of assault or attack or communal clashes in nature, in joint operation with the police. That will provide to the emergency medical personnel some kind of backup, some kind of protection as they try to save lives.
When it comes to payment for emergency services, NEMSAS outlines what an ideal scenario should be in line with the Health Sector Renewal Plan of President Bola Tinubu under the leadership of the Honorable Minister of Health, Professor Mohammed Ali Pate. In a fully operational system, in an accident, for example, an accident victim is picked up and taken to the NEMSAS designated hospital. The patient is then stabilized immediately. The hospital logs the case under NEMSAS. The government reimburses the hospital, and most importantly, the patient is not asked for upfront payments. NEMSAS has provisions to support care for road traffic accidents, mass casualties, and vulnerable patients. Its funding sources include Basic Healthcare Provision Fund, BHCPF, and Federal Emergency Support Allocations.
This talk is still preliminary, and it stems from the experience of what happened in Maiduguri. And our hope is the police force, and I know that they are doing their best to really work with us, would be able to work that out with us.
How difficult has it been to get hospitals, especially private hospitals, to, comply with the obligations for emergency care?
The tariff for ambulances, which initially they've said was low for profitability, has been approved to be revised upwards. It was for the basic life support, 35,000 naira per trip. The last MOC approved 60,000 naira per trip. And the advanced life support was 50,000. And currently it's up to 75,000. So this really is at par with the private sector pricing. And the private practitioners would be able to key in, and this is a very welcome development as well. So really, we did not make a lot of resistance from them because it's a relief from what used to be the case.
What gaps, in your view, still exist in Nigeria's emergency care?
First of all, the number of emergency assets, especially the ambulances.
Okay.
The WHO standard is an ambulance per 100,000 population. So for Nigeria, we expect about, let's say we're only 200 million. We expect at least 2,000 ambulances. And currently we have about 600. So that is a gap. Not only that, we need to have more institutions that will be doing training for emergency medical personnel, and then have sufficient personnel. This is not just time consuming, but also would require a lot of resources. Thirdly, we need to enhance our coordination and communication infrastructure. I've announced earlier that the coordinating minister, as well as the ministerial oversight, has given a go-ahead for NEMSAS to upgrade its infrastructure. So we'll have to get that up and running. Fourthly, like I said, we're operating within an infrastructure within the country that we found. The road networks, the telecommunication services, and the rest. These ones, as they get better, our response to emergency care gets better. Fifth, the awareness of our people to understand that there is this service. It's free, and you should use it. A neighbor's car or your own vehicle or a taxi does not supplant an ambulance, and you should try to take advantage. So we'll have to do more in terms of that advocacy.
What's the biggest achievement, in your view, that the committee has made since it was established?
The biggest achievement is in expansion of the emergency medical services. from 3 states to 36 plus 1 states in the country. The onboarding of 600 ambulances, starting from less than 150 when we started. The increase in the tariff so that private ambulances can key in, and the establishment of protocols and standard procedures for emergency medical personnel in the field to take care of patients at or above the standard that they would have done, if they were left alone. And also the incessant drive towards improvement in the health sector so that emergency services, can be a part and parcel of the integral medical service. You might have seen that the coordinating minister was in France looking at air ambulance. This would change the game in how we operate. Not only that it is a high-tech, intervention, but also because of the nature of Nigeria. Not every city is like Lagos or Abuja. We don't have street names and street numbers. There are emergencies that can happen somewhere. You can't even call a street name. So an ambulance that depends on road route to reach might be challenged, but a helicopter, can find that much easier.
And as we wrap up, your priorities for the next 1 year.
So our priority, I think the first is improving the coordination and communication, for which we have already been given the mandate. And secondly, implementing the standardized protocol care. And thirdly, increasing the awareness of medical services across the country. And finally, trying to reach our target of 1 ambulance for 100,000 population in Nigeria.
In rural communities, we often hear about delays in reaching care, especially for pregnant women. For maternal emergencies, these delays are particularly dangerous because complications can progress rapidly. This is why improving access is so critical. It is not enough for facilities to exist. There must be a reliable way to reach them quickly and safely. Professor Jibrin Ismail, Chairman of the National Emergency Medical Treatment Committee, who's leading national efforts to strengthen emergency response systems, took us on a tour of the Emergency Response Center in Abuja and walked us through how these emergencies are responded to in a timely and efficient manner. Emergency trigger,
Yes.
centralized dispatch notification,
Yes.
driver and facility alert.
Right.
Then you assign a driver. Then transportation. So the
Transportation happens, that is taking the patient
yes
from her home or wherever it happened
to the hospital.
to the hospital.
And then trip validation.
Correct.
So they'll confirm
They confirm that
the
the
center
patient has been dropped.
dropped.
And that is a confirmation by the health facility itself.
Then this is the part that people have questions about, the automatic payments.
Correct. So the drivers, these are either volunteers or National Union of Road Transport Worker members,
Okay.
or even commercial vehicles. Because the problem in the rural area is not just that there are no ambulances, but there is this second delay, meaning when a patient decides that she wants to get help, there is often no mechanism to do that. So these, drivers help to provide that. And they are paid 10,000 naira per trip to encourage them and to make sure that a patient gets there quickly.
All right.
Yes.
So this is the process. So let's now go to where the actual work is happening.
Yes.
And we can see everyone is working. Hello, everyone.
Yes.
Okay, so walk us through what we're looking at here.
So here you're seeing when calls come in,
Yes.
they appear to the operator here with details of the caller, the telephone number. We call these officers centers. They are community-based and they are emergency trained to both triage and to assist in transport of mothers. So that call is picked up, and if that symptom does not exist in our database, because as we said, we're expanding, then they create a file for the symptom.
Okay.
After that, they come here and create a dispatch. Creating a dispatch includes stating where the patient is going to be picked from, and then stating where the patient should be dropped at, based on distance and based on the type of case.
Okay.
Here, as you can see, this is to assign the driver himself. The driver, a particular driver will be assigned, and he's going to go in and pick in the patient.
Okay.
The goal of this is to hasten the transport and to make sure that within the community, whether or not there is ambulance, there are transport mechanisms that would assist patients to go to the hospital quickly. And here is, data of the patient, that, as you can see. And our goal in all of this is to end up with a happy mom and a happy baby.
I mean, it's intriguing to look at, because I'm even seeing in real time here that there are drivers that have been assigned.
Right.
There are some that have been discarded. There are some that are pending.
Yes.
So this is all happening even as we speak right now across the country.
Even as we speak, calls are coming in, and drivers are being assigned and dispatched, and patients are being transported. As we speak, I think the latest number is around 53,000 transports that have happened under this Safe Mama program.
In just a year?
In a year and a half at most.
53,000?
53,000. And majority of them are maternal emergencies, or, cases that happen to be, the mother is in need of help. But about 1,800 of them are the babies that needed help. And in most of these cases, we're able to assist them even before they arrive at the hospital, and then the hospital takes charge from there.
Is this the same process when it comes to accidents and those sorts of emergencies?
Yeah, so the accident is mainly managed at the local, the state, yes. So they have a call center. The NEMSAS that we've talked about has call center, and the call centers manage calls for ambulance transport.
Okay.
But this is a rural program, because most of Nigerians live in the rural area, and they are the ones that are in need of this kind of services.
Our featured National Health Fellow of the evening, Noel Tisandauda, takes us to Kaura local government area of Kaduna State, where he created the Capstone project aimed at optimizing primary healthcare service delivery. In this profile of impact, he shares how his remarkable project is a sustainable community-led intervention using local human resources to resolve primary health challenges.
My name is Noel Tisandauda. I serve as the National Health Fellow for Kaura local government area. My Capstone project focuses on optimizing primary healthcare service delivery. It is a sustainable, community-driven approach that leverages local human resources to solve frontline healthcare challenges. We began with a well-structured community entry process, working closely with local government health authorities. An advocacy team was established, including the Health Secretary, Social Mobilization Officer, the Ward Development Committee, community engagers, and reproductive health focal persons. At Fada Kaguru Primary Health Center, a critical challenge stood out. The labor room was inadequate, forcing women to deliver in the security room. Through community engagement, a health committee was established and led by the Traditional Council member on health. The first major outcome was the expansion of the labor room into a functional 3-bed capacity delivery space. Today, the security room is no longer used for childbirth. Another major barrier was financial access. Many families avoided healthcare due to out-of-pocket expenses. To address this, I engaged with leadership of the Kaduna Contributory Health Management Authority, that is KACHMA, through advocacy and town hall engagements. Traditional leaders, political actors, and community members were mobilized. As a result, individuals, including local stakeholders, began sponsoring health insurance enrollment for vulnerable community members. This led to a 15% increase in health insurance coverage, meaning more people, especially the most vulnerable, can now access care without financial hardship. Manchok Primary Healthcare Center that serves up to 6,000 patients monthly. There is no emergency referral transport system. In critical cases, this delay could mean the difference between life and death. Using the same community-led model, a committee was established to mobilize local resources. Today, progress is ongoing towards the procurement of an ambulance system, a life-saving intervention that is being piloted by the community itself. I deeply appreciate the leadership of His Excellency, President Bola Ahmed Tinubu, and the Honorable Coordinating Minister of Health and Social Welfare, Professor Mohammed Ali Pati.
Speaking with Professor Jibrin Ismail, Chairman of the National Emergency Medical Treatment Committee, highlights 3 key lessons when it comes to emergency health responses in Nigeria. First, coordination is essential. No single part of the system can function effectively in isolation. In complex incidents, this is even more true, especially those linked to insecurity, as multiple actors, ambulance services, health facilities, and security agencies must work together in a structured and synchronized manner. Second, preparedness is critical. Systems must be ready before emergencies occur. In high-risk environments, such as those affected by insurgency, the nature of incidents can be unpredictable, and responders must be equipped, trained, and organized to respond effectively and collaboratively under pressure. Third, speed saves lives. Rapid and well-coordinated response reduces mortality and complications, even in situations where there are security threats. The ability to evacuate casualties quickly and safely to appropriate facilities is crucial. Until next time on Vital Signs on the Front Lines, I am Kayla Megwa, reminding you your health is your true wealth.